All right, so this lecture video is going to cover the topic of cardiac output, what it is, the factors that contribute to it, how we regulate it, and so on. Um, I did just want to say as well that over the last few years I've been on a hiatus for making lecture videos, in fact 3.5 years, and I've gotten some users on YouTube who have asked me, why haven't I been making videos? Unfortunately, my kid brother killed himself 3 years ago, and that was a heart-wrenching experience, and it's taken some time to get through that and regain some confidence in that. So my ability to do this. So trying to come back with this, and I will just say this right now that I am dedicating this lecture video to him. So this one's for you, Patrick. But anyway. Uh, Cardiac output. So what I'm going to do is I'm going to just define what cardiac output is, and then we'll talk about some of the factors that affect cardiac output and the two main variables, heart rate and stroke volume, the direct effects they have on cardiac output, and essentially how we use those two to regulate cardiac output. And then obviously we'll take a look at all the variables put together and map out essentially how everything contributes to what this is. And then the last thing I want to discuss is the importance of having a balance in cardiac output. And I'll talk about that and then just review all the main topics that are going with this. Now, cardiac output, what is it? It's a simple thing to understand. Cardiac output, if you want to define it, it is the volume of blood ejected from the ventricles per minute. Now, some people, if you want to be more generic, you can say that it's the volume of blood ejected from the heart per minute, but let's be a little more specific and say from the ventricles, because as you know, the ventricles are what eject blood into the circuits that they're connected to, the pulmonary and systemic circuits. That's what we're talking about here, is how much blood is leaving the heart and going to these various parts of the body. And cardiac output is the product of two variables. Those two variables are heart rate and stroke volume. Which you would have learned about in previous lecture videos. Remember, heart rate, it's simply how many times does the heart beat per minute, or if we want to be, again, a little more specific with this, we can say, when we're looking at heart rate, we can say how many times are the ventricles beating per minute. And remember, this is measured in BPM, beats per minute. And stroke volume, remember, is the volume of blood, usually expressed, well, not usually, expressed in milliliters per beat. Okay. The volume of blood that is ejected from a ventricle per beat. So every time the heart and the ventricles beat, what is the stroke volume? Is the amount of blood that is being sent out of them every time. Okay, and remember, you can figure that out by taking end diastolic volume and subtracting end systolic volume from that, and you get stroke volume. Remember, end diastolic volume is the volume of blood in the ventricles when they are done filling. Remember, diastole is when the chambers of the heart are in a state of relaxation and are filling with blood. And obviously, under normal healthy circumstances, end diastolic volume should exceed end systolic volume. If we're looking at the average resting heart, we would say the average end diastolic volume is about 120 milliliters per ventricle. And systolic volume, remember, systole would be the contraction and pumping actions of the ventricles, and that would be so therefore end systolic volume would be how much blood is remaining within the ventricles after they have contracted or beat. Because remember, the ventricles don't eject all of the blood that is within them, and there's always going to be some left behind. All right, so on average, we would say that the average resting, now mind you, I'm saying resting, and systolic volume is going to be about 50 milliliters. So if we obviously do our math here, which this is about as good as my math gets, we would say that comes out to 70 milliliters per beat. Okay, so what we're saying here, is the average volume of blood ejected from each ventricle. Now, mind you, this isn't from both ventricles. This is each ventricle at a time. The average volume of blood at rest ejected from the right and left ventricles is about 70 milliliters of blood per beat. That is stroke volume. Okay, and if you wanted to look at a percentage of this to look at the efficiency of the hearts, that is what ejection fraction would be. Remember, that's a percentage, and basically you would, and on average, that would be an ejection fraction of about, give or take, 58 to 60%. Okay, so we're saying about 58 to 60% of the blood within the ventricle has been pumped out per beat. Okay. Now, so it's those two variables put together help create cardiac output. Because obviously, every time the heart beats, the ventricles are going to contract and they are going to send blood out into the circuits they are connected to. So obviously, we have to measure heart rate, and remember that is usually done in beats per minute. And on average, we would say that the average resting heart rate for a person, now mind you, this is a variable number. Let's just go with the 70 beats per minute. It could be 75 for some people. In well-trained athletes, it could be anywhere from 48 to 50 beats per minute. All right, that number can vary greatly. All right. And the average resting stroke volume is about 70 milliliters per beat. If we do our math correctly here, we would say that the average cardiac output is about 4,900 milliliters a minute, or 4.9 liters per minute, because that's a big enough number to convert into liters. Now that should hopefully catch your eye for a moment, because notice this is very close to our average blood volume. Remember, the average volume of blood in a person is about 4 to 6 liters. So basically, at rest, we circulate nearly our entire blood volume through our heart on a minute-by-minute basis. And mind you, that's at rest. When we're talking about well-trained athletes, or not even well-trained athletes, just anybody, when we are stressed out or exercising or something like that, you guys all know what's going to happen to our cardiac output. You know that your heart rate goes up when you exercise and exert yourself, and there's also going to be an increase in stroke volume, so therefore cardiac output can rise. And some of the most well-trained elite athletes in the world can have cardiac outputs that exceed 30 liters a minute. Due to a combination of their heart and other physiologic variables. So mind you that these values can vary greatly, or if someone has cardiac complications, if someone has congestive heart failure, suffered a heart attack, if someone's taking certain medications, that could affect this. This is a number that can fluctuate greatly depending on certain situations. And let's talk about some of those certain situations. Now, the first thing we have to think about is heart rate and its contribution to cardiac output, which this is easy. When it comes to heart rate, it's simply, as I mentioned earlier, how many times the ventricles beat per minute. Obviously, if the ventricles are contracting more times than they are at rest per minute, they are ejecting more blood. All right. And this is something that can easily be measured on various pressure points, such as the radial artery. Remember, a pressure point is where an artery comes closer to the surface of the skin, and you can palpate or feel the pulsating nature of that artery as the left ventricle is ejecting blood into the systemic circuit. Because there's some area, because remember, arteries tend to be a little deeper than veins, but there's just some areas where they get a little close. However, though, you have to be careful with that, because when we're thinking about pressure points and measuring heart rates, even though carotid pulses, as you know, the carotid arteries are in the neck, even though carotid pulses can be felt better and more easily, they could create inaccurate readings or hinder your results, because there are what are called baroreceptors within them that are sensitive to increased pressure changes when we're not supposed to have increased pressure changes. And if you press on them or possibly rub them a little, that could cause someone's heart rate to go down, which could affect the measurement. That's why radial pulses are usually the most accurate pulses to take. All right. Now, one thing to remember about heart rate as well is heart rate is an independent phenomenon that the brain merely influences. It does not initiate. As you learned in previous videos, there is an automaticity to the heart caused by those pacemakers or autorhythmic cells that are embedded within it, within the myocardium. And those pacemaker cells have oscillating membrane potentials that constantly generate action potentials as long as we're alive. Now remember though, the brain can influence heart rate through the use of the sympathetic nervous system and parasympathetic nervous system. Remember, mostly when we're talking about the parasympathetic nervous system, we are talking about cranial nerve number 10, the vagus nerve, and when we're talking about the sympathetic nervous system, the cardiac plexus. All right. Now, So the heart doesn't initiate, I'm sorry, the brain does not initiate a heartbeat. It merely influences the rate at which they do so. And I'm not going to go into depth in that because I have other lecture videos that cover that, the ones on the cardiac syncytium, essentially. Um, and when we're talking about regulating heart rate, this is what's called chronotropy. Chronos meaning time, tropy. So basically, when we're talking about chronotropy, that's rate. Okay, heart rate to be specific. And we have what are called positive and negative chronotropic factors that influence heart rate. Now, if we need to do something like bring our cardiac output up, we need to increase our heart rate because obviously if you want to get more blood out of the heart around the body in a minute by minute basis, then obviously the heart needs to beat more. And those are what we refer to as positive chronotropic factors. Okay, positive meaning they have a positive influence on heart rate, causing it to go up. And then obviously then you should understand what a negative chronotropic factor is. That is something that decreases heart rate and obviously would have a negative effect on cardiac output. Not always, but let's say we're talking exercise type situations. Okay. Now, here's the thing though about cardiac output and heart rate. Eventually, heart rate initially, when it goes up, it will quickly increase our cardiac output. But as our heart rate continues to climb, it will actually be detrimental to cardiac output and start to exhibit an inverse relationship. Okay, can anyone think about why that would be? This is a moment, take a moment here to pause and think about this for a second. How heart rate increasing would actually work against cardiac output. Take a second, take a second. Well, think about this for a second. As our heart rate increases, remember the term diastole. Okay? When the chambers are in a state of relaxation and they are filling with blood. Okay? Obviously, as someone's heart rate climbs, that's going to cause a decrease in the amount of time that the chambers are undergoing diastole. A decrease in diastole equals a decrease in filling time. So therefore, as heart rate starts to climb to higher and higher levels, that means there will be less filling time for the ventricles, and obviously if there's less filling time, there will be less blood for them to eject. So that's why that's not necessarily, so heart rate can actually be a detriment to cardiac output. But however, though, we will talk about factors that overcome the increased heart rate and the decreased time in diastole. However, let's look at some things that could qualify as chronotropic factors. Okay, as you know, the vagus nerve anatomically makes up the majority of the parasympathetic nervous system, and you guys know, always remember that quirky phrase used to describe the parasympathetic nervous system: rest and digest. All right. Rest and digest. The parasympathetic nervous system uses the neurotransmitter acetylcholine and muscarinic receptors. And remember, the parasympathetic nervous system, let's say if we have a heart rate here, I'm sure nobody missed my horrid art while I was gone. If we have a heart rate here, remember we've got the SA node and the AV node. And remember that the vagus nerve innervates the SA node and the AV node, and it basically decreases the rate at which, or just basically decreases the activity of those nodes. It will decrease the firing rate of the SA node. And remember, the AV node, one of the important factors to remember about it is it creates a momentary pause before that action potential is propagated down through the bundle branches to the ventricles. So the vagus nerve will increase that momentary pause. When you put those two together, we will have a decrease in heart rate. So therefore, the vagus nerve is a negative chronotropic factor. The opposite of this would be the sympathetic nervous system. Okay, the sympathetic nervous system would be a positive chronotropic factor. And in the same fashion, sympathetic nerves innervate the SA and the AV node and simply create the exact opposite effects of what I just stated through the use of norepinephrine. And that in turn, the sympathetic nervous system will increase the firing rate of the SA node, decrease that delay at the AV node, thus causing an increase in our heart rate. So therefore, it would be classified as a positive chronotropic factor. And catecholamines, remember during situations of prolonged or extreme stress, catecholamines, that's just the fancy word for adrenaline, norepinephrine and epinephrine, will basically they're just secreted from the adrenal gland to exacerbate the effects of the sympathetic nervous system, and one of those would be increasing our heart rate. Okay. Now, temperature also is a chronotropic factor. If we are in hotter environments or hotter climates, that will cause our heart rate to go up. All right, versus cooler environments that will cause heart rate to go down. All right, excess heat puts a lot of stress and strain on the body. We have to increase blood flow to our skin to try to shed more heat. That's going to cause our heart rate to go up. When we're really cold, our heart rate will go down. We will basically we will route more blood flow to our internal organs, and we try to conserve heat when we're cool. All right. So heat is a positive chronotropic factor. Cool is a negative chronotropic factor. The medication atropine is a medication that sometimes is used to treat bradycardia, which in turn is used to block muscarinic receptors that acetylcholine from the vagus nerve would use to interact with. So basically, making it more difficult for the vagus nerve to interact with the heart will basically allow heart rate to go up essentially. Dopamine basically can also be a positive chronotropic factor, and beta blockers, on the other hand, are negative chronotropic factors. By blocking beta receptors, they help reduce the effects of the sympathetic nervous system on the cardiac conduction system, and also, even though this has nothing to do with chronotropy, reduce myocardial contraction force. Now, calcium channel blockers, there's only a small family of them that really act as chronotropic factors, but there are some that can to help reduce heart rate and deal with tachycardia in certain clinical situations. So, in the end of the day, though, we're looking at normal circumstances without medical complications with people. When it comes to chronotropic factors like adapting to exercise, the sympathetic nervous system will be more active, will be in control of our physiology, and will be using the fight or flight response. And part of that fight or flight response is the sympathetic nervous system taking over the cardiac conduction system of the heart and basically increasing the rate at which the rate at which action potentials travel through the cardiac conduction system. That is actually what is called, so not only will that cause an increase in heart rate, that's also what's called dromotropy, meaning an increase in conduction velocity throughout the conduction system. Okay, so you put that all together, heart rate goes up. And again, if you do your math, if we're going back to this basic formula here, heart rate times stroke volume, that's going to equal that equals cardiac output. And as I mentioned earlier, an increase in heart rate will cause our cardiac output to go up, but will eventually be a detriment to it. And like I said, because there will be a decreased amount of time in diastole, and we have to overcome that. All right. Now, if we think about stroke volume, and again, I've lecture videos that go way more in detail about those factors. If you want more detail, feel free to go back to those. Sorry. When it comes to stroke volume, remember, stroke volume is simply the amount of blood ejected from a ventricle per beat. Okay, and remember, the stroke volume from the left ventricle is being sent into the aorta, which is the beginning of the systemic circuit, and stroke volume from the right ventricle will go through the pulmonary trunk into the pulmonary circuit. Now, within both of these circuits, we need to have an output into these for gas exchange. Okay. And remember, gas exchange within the pulmonary circuit is O2 into the blood, CO2 out of the blood, and gas exchange in the systemic circuit is the other way around, O2 out and CO2 in. So, all right. And remember, stroke volume, as I mentioned earlier, is end diastolic volume. Subtract end systolic volume from that, and you get stroke volume. And remember, at rest, I said the average number for that is 70 milliliters per beat. Okay. Now, and remember, end diastolic volume is purely the amount of blood remaining within the ventricles prior to ejection. So the amount of blood in the ventricles when they are done filling, and end systolic volume is the amount of blood remaining within the ventricles after they have beat and ejected blood. Now, let me ask you this. Which one of those two would be more beneficial to increasing stroke volume? Would an increase in end diastolic volume or an increase in end systolic volume help stroke volume or help cardiac output? Which one do you think? The correct answer is end diastolic volume. we need to increase our end diastolic volume in order to increase our stroke volume. Because remember, eventually, heart rate is going to cause a decrease in stroke volume if we don't do something, if there aren't other factors involved in this process. Because remember, a increase in heart rate equals an increase in diastolic time, which means if the chambers are not filling enough, they will not beat enough. So therefore, we have to rely on other factors that govern, we have to rely on certain factors that govern stroke volume, and there are three of them. Preload, which is just another word for end diastolic volume, contractility, which is called inotropy, and afterload is a factor that influences this as well. All right, now let's think about this. Each one, how would each one of these basically influence this? As I mentioned earlier, when it comes to preload, preload is the volume of blood, end diastolic volume, is the volume of blood within the ventricles. Let's say this is a ventricle right here, when it's finished filling. Now, what will physically happen to the ventricles once they fill? Well, they physically expand. The more the ventricles expand, the harder they're going to contract. I'll talk more about that in a moment. So preload and contractility actually have a correlation with one another. If there's an increase in preload, there will be an increase in inotropy or contractility. So the more the ventricles fill, the more the walls stretch, the harder they're going to contract. All right. Afterload, on the other hand, is the volume of blood remaining within the ventricles after they have beat. And I mean, it should just make sense as to why that would cause cardiac output to go down. If the ventricles have contracted, but they didn't eject as much blood out as they're supposed to, that means that's more blood remaining within the ventricles, which will cause a decrease in output. Okay, now let's talk about each one of these more individually. Preload. Preload this is a really, really crucial idea to understand when thinking about cardiac output and maintaining it. Preload, or end diastolic volume, is governed by what's called the Frank-Starling mechanism. Contributions, these were contributions that were described by Otto Frank and Ernest Starling, German and British physiologists who had a very strong interest in the heart and cardiac output, and more specifically length tension relationships within the muscle tissue of the heart itself. So basically, the Frank-Starling mechanism states that an increase in the volume of blood within the ventricles will cause an increase in stroke volume. So in essence, the more blood that the ventricles fill with, the greater the stroke volume will be, therefore the greater a person's cardiac output will be. All right, now, in saying that, now I mentioned earlier that as heart rate goes up, heart rate eventually becomes detrimental to cardiac output, okay? So therefore, we have to rely on external factors to fuel the Frank-Starling mechanism of the heart. Ventricular, and I'll talk about those in a moment. So there also ventricular compliance is an important factor here. Think of compliance as the walls, the ventricular walls, how distensible they are, how well they can stretch. Because there are certain clinical situations, which I'll show you in a moment, to where the walls of the ventricles actually become quite stiff and don't stretch and expand like they are supposed to or normally would. And the stiffer the walls of the ventricles, the less output there will be. The more compliant they are, the more output they will be. Okay, and as I mentioned a moment ago, preload influences inotropy, which I'll explain more in a moment. All right, but let's look at preload and the Frank-Starling mechanism here. All right, because when thinking about the Frank-Starling mechanism, we have to rely on factors outside of the heart to overcome heart rate, to overcome that reduced time the chambers are in diastole, the atria and the ventricles. Okay, now with the Franks and the ventricles to be more specific. Now, with the Frank-Starling mechanism, one of the big things that's important here, in order to overcome the high heart rate and use external factors to crank our cardiac output up by cranking our stroke volume up, we need to rely very heavily on an increase in venous return. Okay, an increase in venous return. Okay, now, as you know, Arteries and veins have varying amounts of pressure within them. The average mean arterial pressure, you're looking at about 100 millimeters of mercury. Veins on average will have pressure of anywhere from 15 to 25 millimeters of mercury within them, creating a pressure gradient, which in turn creates blood flow. Now, since blood pressure in veins is significantly lower than blood pressure in arteries, blood flows more slowly through veins. Plus, most veins of the body have to work against gravity and carry blood up to the heart, and that obviously doesn't help the cause either when it comes to venous return. So, in order to overcome that increase in heart rate, we need to get more blood back to the heart more quickly. And more blood returning to the heart equals an increase in end diastolic volume or preload. Okay, and one of the ways that we do this, now remember that if we're thinking about a situation like exercise, causes physical stress on the body. And remember, the hypothalamus is the main regulator of the autonomic nervous system. And when we are experiencing stress, the biological way we compensate for it is with the fight or flight response. So when we are experiencing physiologic stress, then the sympathetic nervous system we will increase sympathetic tone on veins. Now remember, blood vessels are only innervated by sympathetic nerve fibers. There's not a dual innervation situation here. Now remember, veins are usually mostly collapsed due to their low pressure environments that are within them. And blood moves through them very slowly. Now, remember, there's always a small amount of tension within the walls, within the muscular walls of blood vessels, because if they're only innervated by sympathetic nerve fibers are always sending out a stream of action potentials, maintaining a certain level of tension. And it's a simple concept. If we increase sympathetic tone to a blood vessel, meaning we increase the firing rate of sympathetic nerve fibers to the muscular walls of vessels, that will make those muscular walls more active, cause the muscles to contract, which in turn cause constriction. All right? And in this case, we would see vasoconstriction. Vice versa, if we decrease sympathetic tone to the walls of vessels, that causes the musculature to relax, and that causes blood vessels to dilate, and therefore that will decrease pressure and resistance. Now, in this situation, what we're doing here by increasing sympathetic tone on veins and causing them to constrict, we're literally squeezing we're causing veins to squeeze against that blood within them, causing more blood to come back to the heart, essentially. The greater the return there is back to the heart, the greater the ventricles will fill with blood. And remember, the more they stretch, the harder they contract. All right. Also, there's other factors as well. Muscular pumps. You got to remember, veins are oftentimes embedded in between muscles. And as muscles repetitively contract, remember, as they are expanding and relaxing, as muscles are expanding and relaxing, they are squeezing against veins that are in between them. And by squeezing those veins, they're causing blood to come back to the heart more quickly, causing a quicker return. All right, there's also what's called the thoracic pump. You guys know that when you exercise, our breath rate goes up, and as our diaphragm contracts and flattens out harder with more force, that puts pressure against abdominal vessels, causing more blood to return back to the heart. So notice a pattern here. We're seeing an increase here. Also, with the same similar mechanism as with the muscular pump, muscles will squeeze lymphatic vessels a lot harder, causing more lymph to flow back into the circulation more quickly, causing blood volume to go up, causing a greater return. When we exercise, we also tend to secrete antidiuretic hormone or vasopressin when we exercise to stimulate the kidneys to retain water. Because when we exercise, we sweat, we lose fluids, and remember, blood pressure is volume dependent. The more we sweat, the more water volume we lose, the more blood pressure will drop. So therefore, this hormone stimulates the kidneys to retain water, keeping our volume levels up. More volume equals more return. All right. And then if the atria are beating more during heartbeats, then that's more blood getting into the ventricles, causing them to stretch more, and they contract harder. So when you look at all this right here, I know I spoke a bit quick on that, but when you look at all these factors right here, these are all factors that in the end cause more blood to flow back to the heart. And the more blood that enters the chambers of the heart, the more they're going to fill and the more they're going to cause the walls of the ventricles to stretch. And that's how we overcome the increase in heart rate and reducing the filling time. We bring more in to fill. All right. And the other important thing here when thinking about preload and inotropy or contractility, excuse me, it's important to understand, just to review sarcomeres for a moment. Remember, sarcomeres have Z discs and have thick and thin filaments, actin and myosin within them. And remember that with cardiac muscle cells, sarcomeres are never like optimally aligned. When a cardiac muscle cell is at rest, for example, okay. Now, this is important because we want these sarcomeres to essentially stretch and expand. Because remember, when a muscle is stimulated to contract, that is when actin, through cross-bridge cycling, when myosin and actin bind to one another, and myosin pulls actin to the center of the sarcomere, causing shortening, which in turn causes tension and force generation. Okay, now, when the walls of the ventricles fill with blood, that's going to cause them to physically walls of the ventricles, idiot. When the lumens of the ventricles, the hollow parts, when they fill with blood, that causes the walls to expand. Okay. Now, as the walls of the ventricles expand, that's going to cause the cardiac muscle cells within them to physically stretch. They're going to stretch. Now, what happens when the ventricles stretch or when the cardiac muscle cells stretch, that's actually going to cause actin and myosin to overlap one another in a fashion to where we have enough myosin heads to interact with actin filaments. The greater the more overlap we have to a certain extent, the more force that these cells can contract with. Okay, there is such a thing, however, as these sarcomeres from being overdistended or overstretched, and also from them being understretched as well. We'll take a look at an example of that in a moment. But that's a key thing there, is more stretch equals more alignment between actin and myosin. The better actin and myosin are aligned, the better they can contract. If you want an idea of the optimal length, we're looking at 2.2 micrometers, give or take. Okay. Now, here's something that's important to understand as well with this. There is such a thing as the ventricles getting too big, and them actually not being able to contract the way they're supposed to. So what you see here on the left, this is a normal looking heart, and on the right you can see, well, this is a problem. Now, there is such a thing as the ventricles enlarging too much. Now, remember that cardiac muscle cells are amitotic. They don't undergo mitosis and they don't divide. Okay? The most common thing that causes this hypertrophy of the ventricles is chronic high blood pressure, chronic hypertension. Okay, valvular stenosis or valvular prolapse can cause these as well, depending on which ventricle there's a stenosis with. But let's look at what happens here. If the ventricles become enlarged. Now remember, if someone has chronic high blood pressure or hypertension and they don't treat it very well, that's gonna put a lot of physical strain on the heart. Okay, and that excess physical strain on the heart is going to cause the ventricles to work harder. Now you guys know that, for example, when you think about an athlete, or just not as just an athlete, someone who just exercises on a regular basis, they have lower than normal resting heart rates. Okay, now that's because when a person exercises, their cardiac muscle tissue, their myocardium, will become more thick. It will actually thicken in size, but there are limitations to how much it will thicken. All right. Now, as the myocardium in a trained heart becomes more thick, it can beat with more force, but at the same time, when it beats with more force, that means it ejects blood into the circuits, more of it with a beat, and that also means that's a greater return as well. So therefore, end diastolic volume with each beat is going to be greater than a person with just an average size heart. So therefore, the heart doesn't have to beat as often. All right. Now, Does that make sense? So again, a person with a like an athlete's heart, for example, like I said, the ventricles can beat with more force, thus having an increase in stroke volume or more blood going into the circuits, which will equal an also greater than normal return at rest. More return equals an increase in preload, and that will also cause an increase in contractility, and therefore the heart doesn't have to beat as many times to get the same volume of blood around the body, which is good for the heart. Okay. Now, someone has chronic high blood pressure, whether it's through renal issues, whether it's through neurological issues, whether it's through vascular issues, you name it. If someone has chronic high blood pressure and they don't take care of it very well, that's going to cause the ventricles to contract harder than normal all the time, and that's bad. Now, the problem here is as these cardiac muscle cells work harder and harder and harder, they're going to get bigger and bigger and bigger. The problem is, though, these muscle cells are eventually going to start to become too elongated, and that's going to cause the sarcomeres to actually be stretched too much. And that's actually going to be detrimental to the overlap of actin and myosin. If actin is pulled out too far from myosin, then there won't be the cross-bridge cycling, the optimal cross-bridge cycling like we want, and therefore cardiac muscle cells won't contract with enough force. Plus, the other problem here with this as well is as these cardiac muscle cells become more enlarged and elongated, there's going to be more connective tissues filling in the space in between them, causing that myocardium to become more stiffened as well. And if the ventricles cannot expand like they used to, and sarcomeres in these muscle cells are not aligned properly, then that's going to equal less inotropy, negative inotropy, and meaning less contractile force. Okay. Plus, that also a lot of times will cause the lumens or the openings of the ventricles to actually become elongated and more narrowed. So that means it'll be harder for them to fill, and it'll also be harder for them to get blood out. When you put all that together, that's going to cause an increase in the amount of blood remaining in that ventricle or ventricles that are enlarged. That means there's an end systolic volume, or an increase in end systolic volume, or an increase in afterload. If you want to boil that down to what it is, that means there's an increased amount of blood remaining in the ventricles that did not get ejected out into the circuits, and therefore that's going to cause someone's cardiac output to go down, and that's bad. And to give you an example of that, oh yeah, I forgot I had this on here. Also, something to think about as well. If someone does have an enlarged heart, because of this, which waves in the EKG do you think would be the most affected by this? What do you think? We're talking about the ventricles enlarging here, and if you want to look, this website here actually has some really good, solid clinical information on this. Depending on which leads you're looking at on an EKG, the QRS complex is going to be the most greatly affected by this, because remember, the QRX complex is showing you ventricular depolarization, and then the ST segment, remember, is ventricular ejection. So you will see basically these waves the most compromised by this, whether it's changes in voltages as you're monitoring on the EKG, the waves are going to look different. I'll let you go to this website and take a look at examples of this, but remember, being that the QRS complex is showing you the bulk of ventricular depolarization, that's where you're going to see a lot of issues on there. All right. And this right here is simply an example of ventricular hypertrophy. Look at the noticeable increase in the size of the left ventricle. That thing is huge. That thing is huge. In fact, the very first patient I ever saw pass away was due to complications associated with this. In fact, the person's x-ray looked almost identical to this. I promise it's not that person's. That was a long time ago. All right. Now, afterload is the volume of blood remaining within the ventricles post-ejection. Now, the problem here with if we have an increase in afterload, meaning if we have too much blood remaining in the ventricles, that goes back to what I was saying earlier. That's going to keep the sarcomeres stretched out too much, not allowing them to realign back to where they need to be, and that's going to compromise actin and myosin's ability to create optimal force. Afterload has a negative effect on cardiac output if it goes up. And again, if you just want to keep it to a simple concept, if there's more blood remaining in the ventricles after they beat, that's less blood going out of them into the circuits. Because remember, that's what cardiac output is, the volume of blood the heart ejects on a minute-by-minute basis. All right, because remember, cardiac output, if we think about this again, heart rate times stroke volume. Okay, heart rate measured in beats per minute, stroke volume measured in milliliters per beat. All right, we can eliminate the beats here, so now we just have milliliters per minute. All right. So if someone's heart is consistently kicking out less blood and there's more remaining in, that's going to cause their stroke volume to go down, and that's going to cause their cardiac output to go down. Okay, and there are various factors that can cause an increase in afterload. If something is impairing blood flow back to the heart, whether it's like an occlusion in a vein somewhere, neurological issues that aren't causing vessels to constrict and dilate properly. As I just talked about, ventricular hypertrophy causing a decrease in compliance and causing ventricles to become more stiffened and enlarged. Heart attacks or myocardial infarction. It should be obvious that if someone has a heart attack, that is death of myocardial tissue. And if those cardiac muscle cells are dying within the walls of a ventricle, it won't be as effective of a pump. It will not have, because it will have a decrease in inotropy. It will not be able to contract as hard. Aortic stenosis. Okay, if the aortic valve or the aorta becomes more narrowed, then it will be harder to force blood from the left ventricle into it, causing more of it to back up into the left ventricle, and valvular stenosis and prolapse as well. Narrowing of the mitral valve, or if the mitral valve prolapses and blood regurgitates back up through it, then that's less output from the left ventricle at the same time. Okay. And when you add all these factors up, they all boil down to the same basic variable. That means they cause more blood to remain inside the ventricles, and that means less blood being ejected from them into these circuits. Now, when it comes to maintaining cardiac output, this is constantly done by the Frank-Starling mechanism. In fact, the Frank-Starling mechanism was described nearly 3 decades prior to the sliding filament theory was ever even talked about. Ernest Starling especially had a lot to say that he, through his research, mostly with dog hearts, that when he was doing research and looking at factors that cause blood to, an increased blood flow back to the heart, he wrote about how when there's a greater end diastolic volume inside of those chambers, he noticed that there was more tension within the walls of the chambers of the ventricles of the heart, and that increase in tension caused them to contract harder. That was before even understanding the exact molecular mechanisms of a sarcomere in the first place. Now, local factors as well. There are many tissues of the human body that release certain chemicals or that will influence blood flow through them. As you know, skeletal muscles, for example, will cause an increase in blood flow through them. Basically, more blood will enter them, more blood will leave them, causing an increase in return. All right, like for example, the pH changes in the tissue environment of skeletal muscles, the temperature changes, and so on. The neurological regulation of blood flow, as well, as I mentioned, when we are stressed out and we need to get our cardiac output up, whether exercise, let's say, we have an increase SNS outflow to veins, causing them to constrict, squeezing more blood back to the heart, causing that increased return that I talked about. There are chronotropic factors. We have an increase in heart rate, so we use the autonomic nervous system to make the proper adjustments to our heart rate to cause our cardiac output to go up. So like I said, initially an increase in heart rate is good because the more times the ventricles beat per minute, the more blood they're going to kick out, but we need to overcome that decreased time in diastole, causing through these peripheral factors, causing more blood to return back to the heart. All right, inotropic factors, remember that catecholamines and the increased stretching of the myocardium will cause the myocardium to contract with more force. Renal regulation of blood volume, whether it's through the kidneys themselves or hormonal mechanisms, making sure, because we want to make sure that we are retaining volume, especially during exercise, to keep our blood pressure up. More volume equals more pressure, all right, and various hormonal mechanisms. So when you put all this together, we get basically the mechanisms behind the Frank-Starling mechanism and cardiac output. So basically, when we're looking at heart rate, the combination of the autonomic nervous system and various hormones cause our heart rate to change. In the situation of exercise, we're talking about increase activity of the sympathetic nervous system and an increase in catecholamines, both equal an increase in heart rate. And then we need to worry about these factors that influence stroke volume. A big one is the increase in venous return to overcome the decrease in filling time by the ventricles. All right. So basically, increase in return helps us overcome this decrease in filling time caused by an increase in heart rate. Remember, when it comes to the autonomic nervous system, the sympathetic nervous system causes contractility to increase because sympathetic nerves also innervate the myocardium of the ventricles, causing an increase in the force that they contract with, and other hormones such as catecholamines as well. And then when it comes to vasodilation or constriction, remember in the situation of exercise, we want to slightly vasoconstrict our veins to cause more blood to return, which will be a positive factor influencing stroke volume. Okay, so those factors in turn will cause an increase in preload, which will in turn cause an increase in contractility, which in turn will cause a decrease in afterload under normal circumstances. Okay, and when you put all that together, we get stroke volume. Okay, and diastolic volume minus end systolic volume. Obviously, we want to have an increased end diastolic volume, so therefore we can have a greater amount of blood being ejected. When you put these two together, we get heart rate times stroke volume, which equals cardiac output. Okay, hope that all makes sense. Now, one more thing I want to talk about as well is the need for a balance in ventricular output. I mentioned earlier that each ventricle has a stroke volume, let's just say at rest, for example, of 70 milliliters per beat. Okay, and obviously that number will increase during exercise due to an increase in chronotropic and inotropic factors, increase in preload and contractility. Now, it is very important that each ventricle's output matches one another. Okay, it's very, very important here. So if we say that the right ventricle ejects 70 milliliters of blood into the pulmonary trunk, which distributes blood in the pulmonary circuit per beat, so must the left ventricle into the aorta and the systemic circuit. Okay, if we have an unbalanced cardiac output between the ventricles, that is going to cause volume overloads of the circuits they are connected to, essentially. For example, let's say somebody had, let's say someone suffered a myocardial infarction, and let's say 15%. Let's say their left ventricle is now working at 15% less efficiency than what it used to due to tissue death. Okay, and let's just say, for poops and giggles, let's say the stroke volume of the right ventricle is 70 milliliters per beat, and now the stroke volume of the left ventricle is 60 milliliters per beat. Okay, that means that the left ventricle is sending less blood than normal into the systemic circuit. Okay, and that means the right ventricle, because all is well in the world, meaning the muscle tissue still structurally intact, is kicking out 10 milliliters more per beat into the pulmonary circuit. That is eventually going to cause volume backup and volume overload of the pulmonary circuit. Okay, and that increase cardiac output into the pulmonary circuit and the decrease output into the systemic circuit will eventually cause pulmonary edema. Okay, due to the volume overload of the pulmonary circuit. When people suffer from pulmonary edema, remember that is when you have fluid buildup in the interstitial spaces within the pulmonary circuit, which will in turn cause pulmonary capillaries to be pushed farther away from alveolar air sacs within the lungs, which compromises gas exchange, which will increase the transit time or the amount of time it takes for these gases to diffuse from air to blood and vice versa. All right, that's why, for example, people need to take diuretics in this, in these situations to try to get rid of that excess volume, especially within the pulmonary circuit. Like Lasix is a common one. All right, and the other way around, if we were to flip this around and say that the left ventricle had an output of 70 milliliters per beat, and the right only had an output of 60, then it would be the other way around. The left ventricle would eventually overload the systemic circuit with volume, and as a result, that would cause systemic edema, where you are going to be having fluid buildup in the peripheral parts of your body, causing swelling and so on. especially in your dependent regions where gravity has the most effects, like your wrists and your ankles and things like that. All right, let's think about this for a second too. So let's say the left ventricle in this situation is kicking out more blood um, into the left, into the systemic circuit, okay, causing overload to happen. Now, remember that if the wall of the right ventricle is compromised and it is pumping less blood into the pulmonary circuit, that's going to cause a decrease in contractility. All right, it's going to cause a decrease in contractility. That means that muscular wall is too weak to keep up. All right. So, but I hope that makes sense as like I said, as to why why ventricular output needs to be balanced. Because if it's not, then that's going to basically cause an increase in volume overload in whatever circuit that is kicking out the higher amount of blood than the other. All right. So to summarize, cardiac output is the product of heart rate times stroke volume and is expressed in milliliters per minute or in liters per minute. All right. And remember, on average at rest, the average cardiac output of a person is nearly the entire blood volume. All right. It is heavily regulated by neurohormonal factors through positive and negative chronotropic factors. Because remember, if we want to if we want to increase our cardiac output by increasing heart rate, we need the nervous system and the endocrine system to help us with this. Remember, the sympathetic nervous system would act as a positive chronotropic factor, and the parasympathetic nervous system would act as a negative chronotropic factor. All right. Fight or flight increases heart rate. Rest and digest through the parasympathetic nervous system causes a decrease in heart rate. All right. Remember, heart rate is important, but there is a certain point to which at which heart rate actually has a negative effect on cardiac output. Because remember, when the heart starts beating a little too rapidly, then that's going to cause an increased time in diastole by the ventricles, and to overcome, remember, did I say increase? I meant decrease time in diastole, and remember to overcome that decrease in diastole. Sorry, we need to use peripheral factors to overcome this. And when I say peripheral factors, we're talking about the Frank-Starling mechanism, and one of these big factors that is very important to this is an increase in return. All right, the return of blood back to the heart. All right. And basically, while Frank and Starling were doing their studies, they were taking hearts, simple but ingenious studies, and they were showing through pressure volume loops that as more blood was entering the ventricles of the heart, they were physically expanding more, causing an increase in length and tension within the walls of the ventricles, which in turn causes them to pump harder. So like I said, even though the heart is beating more often, by getting more blood to return back, causing an increase in preload or end diastolic volume, that causes, remember, sarcomeres within cardiac muscle cells to align at the optimal lengths, which in turn allow them to beat at the optimal force. The other key thing with this as well is as these cardiac muscle cells stretch, and there's neurohormonal factors in this, there will also be an increase in calcium influx into cardiac muscle cells. And remember, as you learn through cardiac physiology, more calcium entering a cardiac muscle cell equals more force of contraction. All right, and again, I cover that more in other lecture videos, but the combination of the optimal length of sarcomeres and the influx of calcium equals more force. All right, and it equals an increase in inotropy or contractility. And remember, under normal circumstances, if cardiac output is up, afterload is down. All right, remember, afterload or end systolic volume is the volume of blood remaining in the ventricles, and the more blood we send out, the more blood that will return. However, if afterload goes up, then it will be detrimental to cardiac output. And remember that it is imperative that each ventricle's output matches the other. Because we do not want volume overload of the pulmonary and systemic circuits, which will in turn cause edema of those circuits, and you guys know the negative consequences of that. But yeah, I guess that's about all I have to say for now about cardiac output. If you have any questions or comments, obviously let me know. If there's anything I need to clear up, because I know some things I went through kind of quick. It's been a few years since I've done this. So just want to thank you all for watching. I appreciate it. And like I said, I hope I did you justice, Patrick. Take care, everyone.